Dr. Hobbs, can you walk us through how ET is managed and really what treatment options are available?
So when we're thinking about ET and its management, the first thing that we need to decide is, does a patient need aspirin or not? So we use a tool to risk stratify patients to decide, is their risk of having a blood clot low or high? And so patients that are very young and have a calreticulin mutation are considered to be at very low risk for having a blood clot. So those patients actually do not require aspirin or any medication to lower their blood counts, almost irrespective of what the platelets are. We can talk about that more in a second. Now, if a patient is older, over the age of 60, or if a patient has a JAK2 mutation, really those patients should be on aspirin unless there is a contraindication. And then the next question we need to decide is, does this patient need to be on what's called cytoreduction, so medications to lower their blood counts? So if a patient is over the age of 60, if a patient has a JAK2 mutation and is over the age of 60 specifically, or if a patient at any age has had a blood clot, all of those patients need to be on medications to lower their blood counts. There are several medications available to help us do that. The most commonly utilized is hydroxyurea. That is a pill that can lower not just the platelets, but lowers the red blood cell numbers as well as the white blood cell numbers. And that's a medicine that's usually readily available, generally well tolerated, and I would say it's probably the most common medication that's prescribed. In addition to hydroxyurea, we have interferons for the use of ET, and interferons have been used for a long time. The only available interferon at the moment is Pegasys, but many patients are likely also getting ropeginterferon or Besremi off-label. And there's been several studies recently using ropeginterferon for essential thrombocythemia. So it is our expectation and hope that this medication will also get approved for essential thrombocythemia sometime in the coming year. Besides that, we also have ruxolitinib or Jakafi that can also sometimes be used off-label for ET, but it is not approved for ET. And then the last medication is anagrelide, which is a medication that really we use very, very infrequently, as it is usually a difficult medication to tolerate.
Excellent. And how can patients partner with their care team and really stay engaged in making that decision on when, treatment is needed and how to have those goal of care conversations?
Yeah, I think it's really important for a patient to understand why or why not they should be on medication to lower their blood counts. So if a patient is considered to be at low risk for having a blood clot, that's really a patient that doesn't need to be on a medication to lower their blood counts. And so I think being able to ask questions of your healthcare team to understand why you're not being placed on a medication is really important. And then similarly, if you're a patient for which medications has been recommended, it's important to understand why that's the case, and also to follow with your doctor regularly to understand, are your blood counts well controlled? Do you have symptoms from these medications, et cetera? And then there's also situations where maybe a patient is not considered high risk for having a blood clot and medications aren't necessarily recommended, but if that patient has a lot of symptoms from their disease, that may be a reason to consider being on a medication to lower their blood counts. And then lastly, there may be cases where patients have really high platelets and they're noting that they have maybe easy bleeding or bruising, especially like gum bleeding or heavy menstrual periods. And that may be a reason to get somebody started on a cytoreductive therapy to lower their blood counts. Because as I've mentioned previously, sometimes when patients have really high blood counts, really high platelets, they can actually be at higher risk of bleeding. And so if a patient is found to be at higher risk of bleeding, that may be a reason to put them on a medication to lower their blood counts. And so having that active communication with your doctor to make sure that they know what's going on and what symptoms you may be having is really helpful.
Dr. Hobbs, what are the approved treatment options for ET and how are those decided upon?
Yeah, great question. So interestingly, there aren't FDA-approved agents for ET, but we do have a few different options available to treat our patients, and hopefully we'll have some approved soon. So when looking at a patient with ET, the first decision that we need to make is whether or not that patient needs to be on aspirin. So we use different factors to what's called risk stratify to determine what the risk of having a blood clot is. So for example, patients that are very young, less than 40, and have a calreticulin mutation are considered to be at such low risk for having a blood clot that they don't need to be on aspirin. But for example, any patient with a JAK2 mutation and patients over the age of 60 should be on aspirin. In terms of medications, if a patient is considered to be at high risk for having a blood clot, meaning they're over the age of 60, and they have a JAK2 mutation, or they've had a blood clot at any time, then those patients should be on what's called cytoreduction, meaning a medication that lowers their blood counts. So the first medication is hydroxyurea, and that is probably the most commonly used to lower patients' blood counts. So this medication can lower the white blood cell count, the red blood cell count, and the platelets. It's a pill. It's been around for a long time, and it's usually pretty well tolerated. The next is the interferon. So the drug that we have available right now is a medication called Pegasys, but hopefully we'll have ropeginterferon or Besremi available to treat ET patients sometime in the next year. So the interferons have been used to treat MPNs for several decades, actually, and they've been demonstrated to lead to excellent control of blood counts and also to reduce the level of the mutations that patients have. So recently there's been a lot of interest in using these medications to treat our MPN patients. We also have anagrelide, a medication that is really infrequently used, mostly because it has a lot of side effects. In particular, patients can feel like their heart is racing. And so it's really not a medication that we use that frequently. And then occasionally we'll also use ruxolitinib or Jakafi for patients, but that's really used more in what's called an off-label fashion because it's not specifically FDA approved for essential thrombocythemia. So when thinking about using cytoreductive therapy, the first thing we do is, do we need to start patients on cytoreduction because they're at high risk for having a blood clot? But there's two other reasons why we may consider lowering patients' blood counts. The first is if they are found to have an increased risk of bleeding. So we can do a test called von Willebrand, and if that level is very low, or if the patient is having signs or symptoms of easy bleeding or bruising, we may start cytoreduction, start a medication to lower those platelets with the hope of also lowering the likelihood of that patient having a bleeding episode. And then lastly, if a patient has symptoms of their disease, so let's say the patient is very itchy or they have a lot of headaches that don't get better with aspirin, things like that, we may consider putting a patient on a medication to lower their blood counts with the hope of also improving their symptoms.
And thinking about, you mentioned that younger patients are being diagnosed with ET. Are there any considerations when we're thinking of, women who may be wanting to get pregnant or any fertility issues or just the younger population in general?
Yeah, absolutely. And thank you for asking that question. So, up to a fifth of patients will be diagnosed when they're younger than 40. So at that age, women are still having periods and they may still be at a point in their life where they may want to consider starting a family. And so I think there's several issues that are relevant to our young women with an MPN. The first is aspirin. So for young women that are still having regular menstrual periods, aspirin can sometimes pose a significant challenge. And I have many of my young women that at around the time when they know they're going to get their period, they actually stop taking their aspirin because they find that they end up having really heavy menstrual periods. So again, a reason to be very open with your healthcare team to talk about all these issues, I think is really important to emphasize that. The next question is really, what about pregnancy? Can a patient with ET get pregnant? And the answer is yes, absolutely. We know that for pregnancy, being on aspirin is really important to improve outcomes in pregnancy. So even our very low risk patients that we don't normally recommend aspirin for, if they're pregnant, we recommend that those patients remain on aspirin throughout their whole pregnancy. If a patient was previously on a cytoreductive therapy because they had a blood clot, then they need to be on a medication to keep their blood counts low during pregnancy. And really the only medication that we can give during pregnancy safely is interferon. And so definitely patients can get pregnant and the outcomes are comparable to the general population, but there are important considerations for a patient. So talk to your doctor about this, and you may need a referral to a high-risk OB to help during pregnancy. And then an important recommendation as well is that patients should be on anticoagulation for 6 weeks after delivery, just to prevent blood clots, because that's a time when anybody with or without an MPN is at higher risk of having blood clots. So definitely unique considerations for our young ET patients. But again, I think open communication and seeing your physician frequently and asking these questions are really important to ensure that patients have good outcomes.
Absolutely, absolutely. And what emerging therapies or advances in understanding ET are you most excited about?
Yeah, so there's lots of research going on for ET. I think the drug that'll most immediately get approved is hopefully ropeginterferon or Besremi. This is a medication that's already approved for polycythemia vera, and we've seen a lot of studies recently looking at this same drug for essential thrombocythemia, showing good responses in terms of control of blood counts and also a reduction in the level of the mutations in the same way that we've seen with polycythemia vera patients. So I think that's the one that I'll expect to get approved hopefully sometime in 2026. In addition to that, there are other medications that are being studied. I think the one that we've heard the most about, where I'm most excited, is the monoclonal antibody therapies directed against calreticulin. So this is where an antibody is used and designed specifically to attach to the cells that have a calreticulin mutation. And so far, we've seen some preliminary data at several of our national and international meetings. And really, it looks very, very promising in terms of controlling blood counts, but also in lowering the level of the calreticulin mutation. And there's many other variations along this theme of other molecules that are being developed, although those are earlier in development. There's also bomedemstat, a medication called an LSD1 inhibitor that's being investigated across the MPN spectrum, but there are 2 different clinical trials for patients with ET, both in the upfront setting, meaning it's the first medication they've received, or for patients that have been on other medications. And so although a lot of the drugs that are being studied are being studied primarily for myelofibrosis, there are several that are also being investigated for ET.